topic I've chosen to speak upon today is, in a 31-year-old G1P0 Vietnamese lady at 35 weeks of gestation, what are the appropriate management options for glaucoma? I felt that LN's alpha-GAN regime was inappropriate during pregnancy. As you may recall, glaucoma is an increased pressure of fluid in the eye leading to progressive and irreversible loss of vision, and is the second cause of blindness worldwide, especially in Africans and Asians. And while pregnancy is associated with a decreased intraocular pressure, glaucoma does need to be managed, as it is a sneaky robber of sight. So effects of glaucoma medications on the fetus and breastfed infants are largely unknown, and there is a defined intervention available, I believe. Our patient is on alpha-GAN 1 drop 3 times a day and follows up every 3 months with her ophthalmologist. And that's a picture of alpha-GAN right there. There are very many management options, but I've broken them down into medications, surgery or laser, and complementary alternative. I will focus on the medications here today. Beta blockers, calcium channel blockers, prostaglandin analogs, and sympathomimetics such as the alpha-adrenergic agonists are discussed here. This diagram shows the anterior segment of the eye, including the cornea, the very front of the eye, the anterior chamber, the space with fluid, as well as the iris, the colored part of the eye, and the lens. The area we want to focus on is the angle between the lens and the iris, as well as the iris and the cornea, and the angle is depicted in this diagram. I like this diagram because it shows the flow of the aqueous humor using the red arrow from the ciliary body between the lens and the iris out to the trabecular meshwork or canal of Schlemm and the uveal scleral area. It would then make sense to have the mechanisms of action of the medications to reduce the production of fluid in the eye or of aqueous humor, or to increase the outflow either by the trabecular meshwork and canal of Schlemm or the uveal scleral route. Notice that alpha-GAN does both reduce the production of aqueous humor as well as allows flow through the uveal scleral method. Alpha-GAN is an alpha-2 selective agonist, and it acts by decreasing aqueous humor production as well as increasing outflow. The concerns here is that there is scant evidence as well as a theoretical risk of alpha effects in the fetus. It's also contraindicated in infants and children. A Medline and PubMed search using the terms glaucoma, drops, alpha-GAN, and pregnancy found me many articles. Of note, this commonly cited landmark study by Dr. Ho examined anti-glaucoma meds and the association of low birth weight, defined as less than 2,500 grams, the WHO definition. A sample size of 244 in the treatment group was compared with a sample size of 1,952 in the control group. The majority of the treatment group used timolol drops, which is a beta blocker, and reduces the amount of aqueous humor. Both groups were adjusted and matched for characteristics using multivariate log regression, listed here. After adjusting for confounding variables listed above, they found 2 conclusions in this study. There's no significant difference in the risk of low birth weight infants between mothers prescribed beta blockers and the control group. Notice the odds ratio and the confidence interval. And the second conclusion was that there was a significantly higher risk of low birth weight infants for mothers prescribed topical meds other than beta blockers. So this includes our medication of alpha-GAN. Overall, this study showed that topical beta blockers can be used as first-line drugs when considering the medical treatment of glaucoma in a pregnant lady. Another study done by Dr. Stacy Browner in 2006 studied the course of glaucoma in pregnancy. There was a small sample size of 15 with glaucoma and 13 in the control group. This was a retrospective study which analyzed the confounding variables of age, race, meds, glaucoma type, either open angle or closed, visual field analysis, IOP, before, during, and after pregnancy, and only 13 of the 15 pregnant ladies used anti-glaucoma drops. The results showed that more than half showed no progression of disease, the IOP was stable, and no visual field loss. Now, in 17.9 or 20, almost 20%, IOP increased, but there was no visual field loss. A Medline and PubMed search also found other literature, mainly reviews of glaucoma in pregnancy. Of note, Kuhner et al. in 1988 made two major landmark reviews commonly cited, as well as Dr. Fleisch in 1991. All of these showed inconclusive and either do not specify nor recommend alpha-GAN in pregnancy. There are limitations to the literature available today on anti-glaucoma medications. First of all, they are retrospective mainly as opposed to prospective studies, as well as few studies being specifically done on alpha-GAN. The bias in regional and ethnic sample size is significant since we know that region and ethnicity is a major factor in glaucoma development. There is also limited and inadequate sample size in the studies. Only 20 pregnant women, for example, in Dr. Ho's study were prescribed brimonidine, which is alpha-GAN, and 2 of them had low birth weight infants. In Dr. Browner's study, 4 pregnant women were prescribed alpha-GAN and no adverse effect was reported. My conclusion here is that with the nature of retrospective analysis, inadequate sample size, small number of studies specifically done on anti-glaucoma meds, let alone on alpha-GAN, does not allow a definite conclusion to be drawn about the safety of brimonidine tartrate. I just want to mention that there is a case study of cyclodiode laser use during pregnancy. However, in the case of an emergency, PI is still used as a standard treatment where they punch holes in the iris to relieve the pressure. Acupuncture and marijuana has been cited as an option in glaucoma treatment, and there are 2 cases that show subjective central visual acuity improvement. However, glaucoma, as you may recall, damages mainly the peripheral visual field. There was no improvement in the pressure or retinal exam, and I was not able to find any evidence of satisfactory trials. Since there is limited evidence for these drops in glaucoma, it would be appropriate to continue monitoring the baby as usual and have her continue following up with her ophthalmologist every 3 months for the exam. Postpartum, we can possibly switch to timolol 2 times a day and have her switch to alpha-GAN P, which has purite as the preservative and may reduce the amount of allergies that she was having. Future inquiries include more analysis in general to assess for safety of anti-glaucoma meds in pregnancy. I'd also like to know about the rebound effect of increased IOP postpartum as well as the role of laser, PI, or cyclodiode in pregnancy. I realized that Dr. Browner in 2006 slightly touched upon this in her study, but since the intraocular pressures decreased in pregnancy anyways, is it possible to remove or reduce anti-glaucoma medication doses in general? I was also surprised to find that the FDA classifies most of the frequently used topical anti-glaucoma meds as Category C, whereas strangely enough, some pathomimetics such as alpha-GAN are the only topical meds classified as Category B. I'd like to see more evidence comparing these agents.